Hello, my name is Eugene. I'm a third-year medical student at the University of Maryland. Today, I'd like to talk about functional neurological disorder, or FND, and share some important takeaways that have changed how neurologists approach this condition. Firstly, FND is diagnosed by positive clinical signs, not just simply because imaging or laboratory tests are normal. For many years, FND was viewed as a diagnosis of exclusion or was dismissed as all in the patient's head. We now know that's not true. FND is a genuine neurological disorder in which the brain has difficulty controlling movement, sensation, or other neurological functions despite the absence of damage to the nervous system that can be measured. Patients experience symptoms that are real, involuntary, and profoundly disabling. These symptoms are not intentionally produced or fabricated. It's good to keep that in mind. Patients with FND can present with weakness, tremors, gait abnormalities, sensory loss, or episodes that might resemble a seizure. At first glance, these symptoms may look identical to a stroke, multiple sclerosis, Parkinson's disease, or epilepsy. How do we distinguish FND from other neurological conditions? Um, the answer really lies in what we call internal inconsistency. So that's findings that are inconsistent with known neuroanatomy um, that change depending on the task being performed. One example is called the Hoover sign. Let's imagine a patient that tells you they can't lift their left leg because it feels weak. So when you ask them to lift that leg off the bed, they barely generate any movement of that leg. Instead of focusing on that weak leg for this test, you'll place your hand underneath the heel of that weak leg while asking the patient to lift the other, or the right leg in this case, unaffected leg against resistance. So most people don't realize that when we lift one leg, the brain automatically pushes the opposite leg downward to stabilize the pelvis. If you feel that the supposedly weak leg is pushing firmly downward onto your hand during this maneuver, it tells you that the motor pathways are intact. The patient is incapable of generating normal strength automatically, even though they can do so voluntarily when you test it. This would be called a positive Hoover sign. With this, we have to really emphasize that this does not mean that the patient is pretending or trying to deceive you. Instead, it reflects a disruption in that voluntary motor control while the automatic movement remains preserved. Another test we could do, depending how the patient's presenting, is called the tremor entrainment test. Again, let's imagine a patient that has a rhythmic tremor in their right hand. You can ask them to tap steadily a rhythm in their left hand, so the other hand, perhaps let's say like once every second. In F and D, the tremor often changes its speed. It could pause briefly or even begin to match the rhythm of the tapping hand, and you could try this at home. It really does work. By contrast, tremors caused by Parkinson's or essential tremor generally have their own characteristic rhythm, regardless of what the other hand is doing. Again, we're not trying to catch the patients in a contradiction or a lie. We're just trying to identify positive exam findings that support the diagnosis. Recognizing these signs has important clinical implications, right? First, it helps avoid unnecessary diagnostic testing, repeated hospitalizations, and invasive procedures that may not benefit the patient. Secondly, it allows clinicians to explain the diagnosis with confidence. Research has shown that patients really respond better when we explain that their symptoms are real and arise from a problem with how their brain might be functioning, rather than getting all the test results back and just saying they're normal. And finally, treatment is multidisciplinary. Specialized physical therapy is often a cornerstone of recovery for these patients with motor symptoms. Many patients also benefit from cognitive behavioral therapy, or CBT, of treatment of coexisting conditions like anxiety, depression, or PTSD. The goal is not simply symptom management, but helping patients retrain normal movement patterns that will, eventually hopefully improve their quality of life. Just some key takeaway points. One, FND is a real neurological condition with involuntary symptoms. Two, the diagnosis should be based on positive bedside findings like the Hoover sign, and not solely just ruling out the other diseases. And finally, we can communicate this diagnosis with confidence, right? That the diagnosis really matters and it has a clear and validating explanation that helps patients understand their condition, build trust with their physicians, and can really be a first step towards recovery. So that's all I wanted to say about FND, and I thank you for your time.